Thank you so much. We're so looking forward to the meeting in Los Angeles in May, and the theme really overlaps with our theme this week. So excited to have APA here. Thank you. And now, it's my great pleasure to introduce Sarah Gottfried-Zoll, who is a physician. She's an educator and a researcher and a colleague of mine at the Marcus Institute of Integrative Health at Thomas Jefferson University, where I work. Sarah Zoll is the director there of precision medicine. Her focus is on the interface of mental and physical health, women's health, personalized molecular profiling, use of wearables, how to leverage these tools to improve health. Dr. Gottfried graduated from Harvard Medical School and MIT and did her residency training at the University of California at San Francisco in obstetrics and gynecology. She's a global keynote speaker and the author of 4 New York Times bestselling books about trauma, hormones, and health. Please join me in welcoming Dr. Sarah Zoll.
Hey everybody, how are you feeling this morning? Are you motivated now to play tennis, run for 30 minutes while you pop berries and nuts? I'm super excited about that. So I want to talk to you about novel approaches to toxic stress and trauma, and I want to thank Dr. Madeline Becker for inviting me to be here today with you all. I had no idea how prescient it was to be talking about this the week of an election. I also want to thank Dr. Amy Bauer for your work, making sure that the content is really relevant for you guys. No disclosures. Back in 2018, imagine what you were doing in 2018, that was 6 years ago. I gave a talk at Thomas Jefferson, and it covered this particular study. So I want to tell you a few things about cortisol and what happens to the brain. So this was a study looking at 2,200 Framingham Generation 3 people. And what we found was that when you look at these folks, all of whom were in middle age, so mean age of 48, 53% of them were women. We found that in these folks, if they had high morning cortisol levels, they had a number of outcomes. The first was they had worse memory and visual perception. Not so surprising. But we also found that they had lower total occipital and frontal lobar gray matter volumes. And then the part that was maybe the most disturbing was that in women, not men, the people with high cortisol had lower total cerebral brain volume. And there was no effect by some of the confounders that you might imagine, like ApoE, imaging traits. So when I presented this slide in 2018, I remember as I was getting to know Dr. Madeline Becker, we both had the same response to this study, which is, I am so screwed. So I was really curious about the study, and of course I wanted to see if it could be replicated. So you know about trauma. I don't feel like I need to define it for you. But one of the points I want to make is that when I first started to learn about trauma 35 years ago, there was an understanding about how it becomes biologically embedded. So all of you are psychiatrists, you work in the mental health field. I'm at the interface of mental health and physical health. And one of the things I care about is biomarkers, meaning how do we measure trauma in the body? How do we measure toxic stress? Because traditionally, psychiatry doesn't have a lot of biomarkers. And I think it's critical, at least in my work in precision medicine, that we identify the biomarkers that really reflect the inner world of our patients, including the experience of trauma and toxic stress. So that's really the focus of my talk today. And I want to cover the evidence that chronic psychological stress is a major risk factor for chronic disease states. So not just depression, post-traumatic stress disorder, anxiety, but also more than 45 different chronic diseases. So as I thought about that study from 2018, and I started to look for replication of this study, I was delighted this year that my friend, Dr. Lisa Mosconi, published a new paper about cortisol in men and women and how that affects the brain. Importantly, when you're looking at that data from 2018, those were not people showing shrinkage of brain volume with high cortisol late in life. Those were people in their 40s. And once again, Lisa also looked at men and women in middle age, 40 to 65. Here's what she found. She looked at a total of 277 people, and she measured cortisol levels in the blood, total cortisol. She found that those who had higher cortisol had lower total brain volume, so confirmed the study from 2018. And here's where things get a little worse. She also found lower glucose metabolism in people with higher cortisol, especially in the brain. She also found that there was a higher beta amyloid load in people with higher cortisol. So she's starting to connect the dots in ways that I think are very important. Background. So one of the points I want to make, and my focus at Thomas Jefferson, is looking at metabolic health. And I'm especially interested in how the experience of toxic stress affects metabolic health. Oh, that would be great. Thank you. Yeah. Travel tends to dry us out, doesn't it? Not a good lifestyle factor here. So a couple of things about this. I want to focus on the data that we have on adverse childhood experiences and metabolic outcomes. So one of the things we know from looking at ACE scores and how that then maps to prediabetes and diabetes is that for men, if a man has an ACE score that's greater than 4, that's associated with a greater risk of diabetes. For women who have an ACE score greater than 1, that's associated with a greater risk of diabetes. So the point I want to make is that documenting an ACE score in all of your patients, knowing what it is incredibly valuable when it comes to some of these physical manifestations of toxic stress and trauma. We can measure toxic stress in the body. There's so many different ways to do it. So I do multi-omic profiling in my patients. I'm involved in executive health at Thomas Jefferson. I take care of a lot of men as well as women. I take care of professional athletes. I'm really honored to be taking care of the Philadelphia 76ers. I also take care of a lot of perimenopausal and menopausal women. And we know that the gut is especially sensitive to toxic stress and to a disrupted cortisol signal. So how does it affect the gut? It affects intestinal permeability. And this is really important because you can measure it. And I have to tell you, looking at the Philadelphia 76ers, out of all of the guys that I've tested, I've only found one who didn't have increased intestinal permeability. All the rest have, of course, a high training load, and that's one of the things that can create leaky gut. We can also measure altered stomach acid and changes to digestion. Cortisol drops the front line that you have in terms of the defense of your gut. It drops secretory IgA. It increases the risk of dysbiosis. And there's a link to neuroinflammation that is still developing. So Dr. Viss talked about the microbiome, and I think it's worthwhile to talk a bit about the microbiome with you today. How many of you measure cortisol in your patients? A few of you. So I'm going to hope to convince you to do more testing of cortisol. Does anyone do gut testing looking at the microbiome? Okay. So when it comes to the microbiome, what we know on the left-hand side are some of the things that are associated with dysfunction of the microbiome. So things like being born by a cesarean section versus vaginal birth, being bottle-fed instead of being breastfed. We know all of those things, but on the right, I want you to understand how the immune system becomes disrupted by changes in the microbiome. And that includes inflammatory bowel disease, as you might imagine, but it also includes things that you might not imagine. Things like type 1 diabetes, multiple sclerosis. And I added this citation in the middle that post-traumatic stress disorder is associated with very significant changes to the microbiome. When I was working on my last book, I became so impressed by the immune system, its dynamic range, and how it can become dysregulated and fly below the radar of most people as well as their clinicians. And so I wanted to describe what happens when the immune system is not fully resolved. So there's a number of different outcomes. You're familiar with mental health problems, but we also want to consider some of these other conditions that you're seeing in your practice. Things like autoimmunity, which typically exists for about 7 to 14 years before a diagnosis of autoimmune disease. And it's in that period, the 7 to 14 years, that I'm doing my work, because I really work at that space between the progression from health to pre-disease to disease. And I want to catch people as early in that process as possible. The incorrect resolution of the immune system can also map to metabolic dysfunction. Do you know how common metabolic dysfunction is right now? It blows my mind. So we've been tracking this pretty carefully over time, and right now, 93% of Americans have metabolic dysfunction. 93%. That is astounding to me. And where do you want to look in terms of metabolic dysfunction? Yes, you can look at fasting glucose, hemoglobin A1C, fasting insulin, 2-hour glucose challenge test. But you also want to look upstream at the mitochondria. 25 million people in the United States have autoimmune disease. That's pretty common. When you do the kind of work that I do, which is precision medicine, deep phenotyping, big data streams, what's interesting about this number is that if you look at the number of people who are on the train progressing to autoimmune disease, it is really high. So I was the chief medical officer of a health tech company in the late 2010s, so about 2018 to 2020. We did a study looking at our employees, a total of 1,000 employees, and we did functional medicine testing, including looking at things like anti-nuclear antibody, thyroid peroxidase antibody, anti-thyroid globulin. And we found that about 30% of our employees out of that 1,000 had positive anti-nuclear antibody. Not just by a little bit, but a significant elevation. Now, I was taught in medical school that anti-nuclear antibody it's non-specific, it doesn't really mean much unless it's together with a constellation of other symptoms. And I don't believe that anymore. So 30% of our population had positive anti-nuclear antibodies. It was the biggest bucket of problems that we identified in our employees, mostly healthy folks. Fast forward to 2024, I was having a conversation with Dr. Mark Hyman. He's a friend of mine. I was on his podcast a few months ago. And he has done functional medicine testing on 100,000 people. So much bigger study than the one I did 6 years ago. And he found that 30% of this 100,000 people have positive anti-nuclear antibodies. So if you look to your right and your left, 1 out of the 3 of you have positive anti-nuclear antibodies. And you're not gonna know that unless you're testing. So I'd really encourage you, in addition to playing tennis, cycling, jogging, eating your nuts and berries, that you check your cortisol and you check your anti-nuclear antibodies. The other problem with this 25 million people is that they typically see 4 to 6 physicians before they get a correct diagnosis. And they struggle for about 4 to 7 years waiting for that diagnosis. You guys are specialists at the autonomic nervous system. I don't need to describe it to you. How many of you measure heart rate variability in your patients? Heart rate variability, HRV. How many of you measure heart rate variability in yourself? Oh, good, okay, few hands. Dan, we gotta measure yours. So, how many of you use wearables? I assume it's the same group. Great, yay. Right now, about 50% of Americans use wearables. We believe in the next 5 years, it's gonna be closer to 100%, and about 50% of them will be implantable, like the continuous glucose monitor. So these large data streams are coming your way. And I think measuring heart rate variability is one of the most important metrics that I find in my patients, as well as myself. I want to talk about women for a moment. I am board certified as an obstetrician gynecologist, and I've been taking care of men for about 20 years. And when I went to medical school, started 35 years ago, there was this massive women's health gap. There was a research gap, a knowledge gap, a treatment gap. And over the past 35 years, that gap has gotten worse, not better. And I want to talk about some of the metrics involved in this. When you think about the life cycle of a woman, and we think about premenopause, which is shown on the left, perimenopause, shown in the middle, and postmenopause, shown on the right, it's important to realize that as women go through these hormonal transitions, it's not just the ovaries that are dictating the hormonal story. It's also the metabolic system, the immune system, and you can summarize this here. Focus first on the blue line. So as we shift from premenopause to perimenopause to postmenopause, there is a nosedive in terms of glucose metabolism. So this occurs because estrogen is the primary regulator of the female body, and as it declines, it leads to faltering mitochondria, and glucose metabolism dramatically changes. So a lot of women notice that their fasting glucose starts to climb, maybe within the average range, but I don't really believe in medicine for the average. I believe in optimal ranges. And I think there are ways to prevent this decline in glucose metabolism. There's also major changes in the immune system, in the innate and adaptive immune system, as women go through these life cycle changes. There are changes that occur in the blood vessel, and you can measure toxic stress in the blood vessel. I know it's hard to see it, but I measure all of these biomarkers in my patients, in every single patient I see, so that I can benchmark where they are in this progression from a normal blood vessel to a vessel that's full of plaque and a thrombus. So we're able to measure that with a simple blood test. To me, one of the most important aspects of toxic stress, issues with high cortisol and trauma, is the way that it affects the female brain. So once again, as we march from premenopause to perimenopause to postmenopause, there's a relatively stable level of cognitive function through premenopause. How many of you have kids? Yeah, so women who've had children know that it's not quite that stable. Sometimes there's a significant drop because there's a lot of pruning that happens postpartum. There's a massive change when your estrogen goes from sky high and progesterone goes from sky high down to nothing when you deliver your baby in your placenta. And there's about a 2% loss of total brain volume, but we tend to come back up. But then there's a decline that occurs in perimenopause, related to the 80% of women in perimenopause who have significant symptoms. And what we know is that the sooner that you intervene and in good candidates start hormone therapy, you can actually get back to a baseline level. But we also know from the Women's Health Initiative that if you wait too long, if you wait until an average age of 63 and you start hormone therapy, it could actually worsen the rate of dementia, Alzheimer's disease. When it comes to perimenopause and menopause and the vulnerability of women, we know something that is relatively new, and if you learn nothing else today, I want you to understand this. Women who experience hot flashes and night sweats, and that's 80% of women across the board, it's not just a nuisance that could be medicated with hormone therapy. It's actually a biomarker of a worsening cardiometabolic profile. It's a biomarker of a greater risk of osteoporosis. It's a biomarker of cognitive impairment. So hot flashes and night sweats shouldn't be seen as an inconvenience. They should be seen as a biomarker of worse things to come. And when you don't treat them, They develop vascular instability that then projects to this greater risk of chronic disease. Suicide risk is highest in women 45 to 55. We know that men tend to be completers, women are more attempters, but we need to understand that this massive hormonal, metabolic, and immune shift that women experience 45 to 55 is also a suicide risk. Lisa Mosconi at Cornell has performed some really interesting studies looking at the female brain in transition from premenopause to perimenopause to postmenopause. So I'm going to walk you through a typical PET scan for women who are making this transition. And I imagine as psychiatrists, you're familiar with looking at PET scans. The main idea here with the FDG PET is that we're looking at areas that are red and yellow that show heightened glucose uptake. So all the areas that are red and yellow show increased metabolic activity. Premenopausal brain has a lot of red and yellow, a lot of glucose uptake. Then we shift to perimenopause. And as your eyes shift from the left image to the right PET scan, you'll notice a decline in the areas that are red and yellow. There's about a 20% decline in glucose uptake in the brain just as women shift from premenopause to perimenopause. And then there's about another 10% decline as they shift to menopause. So overall, pretty dramatic change in terms of the way the brain utilizes glucose, which we think is related to the mitochondria, and how the decline of estrogen leads to mitochondrial dysfunction. Lisa says, if you look at the brain scans of men and women at midlife, their 40s through their 60s, the women show more plaque, more brain atrophy, reduced connectivity, and reduced glucose metabolism. We should not think of dementia as a disease of old age. We should think of it as a disease of middle age. So if you think about the patients you're taking care of who are 45 to 55, 80% of them have these changes occurring. And you want to be thinking about that, especially in terms of some of the lifestyle medicine that could be helping them improve their glucose metabolism. Quick case, I've got a 52-year-old female who came to see me with new onset type 1 diabetes. She was diagnosed with GAD65 antibody. She had just gone through menopause. It occurred about a year before I saw her. She had a number of different symptoms, hot flashes, night sweats, which now you think, okay, that's a biomarker of chronic disease. She had had an elevated anti-nuclear antibody a few years before I saw her. No one did anything about it. She had a sudden diagnosis of type 1 diabetes right around the time of the start of the pandemic, when her intake of fresh fruits and vegetables went down dramatically. She also had an ACE score of 9. So there's some additional information about her. She was on metformin, but one of the problems with metformin was that her glucoses were running too low at night. So metformin wasn't really the answer to try to get her glucoses into a better place. Her hope was to try to extend her honeymoon period to preserve some function of the islet cells in her pancreas so that she could avoid going on insulin. She also had a problem with her cortisol levels. So cortisol is shown on the lower left-hand side. she woke up in the morning with a low cortisol level. She would then spike pretty high at 60 minutes to an elevated cortisol level. The rest of the day, her cortisol was pretty good. This is an example of dried urine testing for cortisol. This is what her glucoses looked like when I first started seeing her. I recommended a continuous glucose monitor, and she was pretty spiky. So with your glucoses, you don't want to be spiky. You want to have a relatively even glucose level. So we started a few treatments for her. I put her on the Institute for Functional Medicine cardiometabolic food plan. We started meditation. We did some other changes in terms of dealing with her dyslipidemia. We also started some immunomodulation. I'm not going to talk a lot about that, but pretty much every patient I take care of with autoimmune disease has low DHEA. I like to keep DHEA around 100. We also started her on low-dose naltrexone. Her vitamin D was low, and that was critical in terms of helping her with her increased intestinal permeability. There's 3 things that are associated with autoimmune disease, and this was discovered by Alessio Fasano at Massachusetts General Hospital. Number 1, genetic predisposition. Number 2, increased intestinal permeability, so-called leaky gut. Number 3, a trigger. And the trigger could be infection, could be getting sick with COVID, but it's also possible that it's trauma. Another common trigger is perimenopause and menopause. So this is her glucose now, after mostly lifestyle medicine plus some immunomodulators. We also started to work on her trauma with the neuro-emotional technique. So this brings up personalized treatment, which is what I do with all of the clients that I take care of. And first, when it comes to measuring trauma, I want to say a couple of things about ways that you can measure trauma in your clients. So I like to use validated questionnaires. I use the perceived stress scale quite a bit in my practice. I do a lot of heart rate variability testing, and one of the options that will become more widely available, I use it now, is that you have a dashboard for your patients where their heart rate variability data is coming into a centralized place. I like to do that with my patients, especially the NBA players, because I can look and say, I can call them or next appointment say, you know, your HRV was so amazing when you were in Los Angeles. What were you doing? Because it was double what it usually is. And I'll get an answer back. I went to the most amazing music concert and I just loved it. Or I find that pretty much all of my patients, when they go to Costa Rica, their HRV triples. And then likewise, I can say, your HRV was so low last night. What was going on? Oh, I did another tequila experiment. And that tends to lower, alcohol lowers your HRV for about 7 to 8 days. So we can measure trauma in other ways. We can measure it with the gut. We know that a flat cortisol diurnal pattern is the most inflammatory. This is the kind of pattern that Rachel Yehuda measured in patients with post-traumatic stress disorder. It's also associated with anxiety, depression, cardiovascular disease. Heart rate variability. So I hope that you, as an action item, will measure your cortisol, measure your heart rate variability going forward, because it sets you up to do N-of-1 experiments, like the tequila experiment. what are some of the lifestyle medicine approaches to toxic stress and immune health? The first is regular exercise, and Dr. Viss, you did a beautiful job describing the data that we have on this. But there's other things too: gardening, restorative sleep. I did not get restorative sleep last night, and yet my HRV this morning was quite good. You can ask about that later. Meditation, trauma-sensitive, mindfulness-based stress reduction, yoga, qigong, nutritious whole food, neurofeedback, EMDR, HRV training, such as with HeartMath. Neuroemotional technique, which I mentioned we used with my 52-year-old patient. It's something that we've published on quite a bit at Thomas Jefferson. The other thing that we've published is data on orgasmic meditation. Now, this is a family show, so I'm not going to talk a lot about orgasmic meditation, but it's pretty interesting, the brain effects and the trauma benefit when it comes to this particular intervention. So I'm going to skip to healing states of consciousness. I know you've got a talk today or tomorrow on psychedelic medicine, psychedelic-assisted therapy, and I think there's many different ways to enter healing states of consciousness. I'm a big fan as an approach to trauma. So I just want to summarize that cortisol is something that you can measure in your clients. When I first measured it 20 years ago in my 30s, I measured it in my blood, and my level was 3 times what it should be. And I remember I called one of my mentors, Luann Brizendine, a psychiatrist at the University of California, San Francisco, and I said, "Hey, Luann, my cortisol is 3 times what it should be." And here's what she said: "Sarah, welcome to the club. Every female physician I know has a cortisol that's 3 times what it should be." So you're not going to know unless you measure it. The network that is most vulnerable to toxic stress and trauma, we know, is the PINE network: your psychology, your immune system, your neurological system, and your endocrine system. We want to be thinking about hormonal transitions, and especially the ways that women are more vulnerable. And then we want to be thinking of what are the N of 1 experiments that we can be doing with our patients. So with that, I'm going to end. I don't know if we have time for questions. Let me just check in with the bosses here.
Can we all give a big round of applause for Dr. Zoll? What an amazing, amazing presentation. I think with the questions coming in, you've stimulated a lot of thought amongst our audience.
Oh, good.
And I don't think that we can possibly get to many of the questions that I would love to share with you. But one of the questions that came in was if you could make some comments on this amazing personalized medicine approach for those of our colleagues who are working in safety net settings and for patients who maybe have difficulty affording to get testing done. How can we help those populations get access to what is arguably the future of personalized medicine?
Yeah, it's a good question, because the kind of medicine that I practice is expensive. It's not always covered by insurance. So I think that's where validated questionnaires can become helpful, because they're free, like the perceived stress scale. It's where having a wearable, like a Fitbit or a Whoop or an Oura Ring, where you're measuring heart rate variability and you're doing experiments, I think can also be very helpful. I feel like we need to, we're moving into this more digitized era of medicine, where I hope that insurance and FSAs will do a better job covering wearables so that we can integrate that into our patient flow.
Excellent. And for those folks who already are measuring or thinking about measuring heart rate variability, I think you've convinced some folks. Do you have a target that you want people to be looking for?
So I don't like to give targets with heart rate variability because it depends so much on the individual. The point that I think with HRV that matters is that your level is improving over time. So I can tell you my NBA players have an HRV that is pretty consistently above 100, even though they sometimes eat at Chick-fil-A. So they have quite a good HRV. A lot of the men that I take care of that exercise regularly, they have an HRV between 60 and 80. Depends on age, because it goes down with age, although I'm not sure it has to. And then women in perimenopause, that's probably the worst group that I take care of in terms of HRV. Their numbers are often in the 20 to 50 range, but the absolute numbers don't matter as much as the experiments that improve it over time, like going to Costa Rica.
Well, unfortunately, we are out of time. I want to thank you again for an incredible talk. I have a couple of announcements, but before we do that, let's show our appreciation for Dr. Zoll. And thank you all for joining us on our wonderful opening plenary session today. We have a break now.